So the title is Global Implementation of National Lung Screening Programs. What are the key considerations? Well, that's what we've been doing all along. We've had institutions participating from all around the globe that have allowed us to really develop screening programs. So when we started in 2000 after the Lancet publications, we did it by having a principal investigator who was very enthusiastic about screening, and they were either surgeons, radiologists, or pulmonologists, and they obtained an institutional review board review to start to use the protocol. We provided the training and the management system, and these conferences every 6 months that has gotten us to where we are now. And that's a possible model to use. So what are the key components really of the screening regimen? They're what is the interval between screenings? You want to separate the baseline protocol from the repeat screenings. You want to define the nodules, how to measure the nodules, how to assess growth assessments, and the thresholds for invasive and non-invasive workup. And you want to make sure that as you're doing the screening, you provide data to continuously update the diagnostic protocol. And we're now looking at integrating AI. So it's a continuous, ever developing process that you need to have the data from your program. That's how we developed the growth analysis, and that was long ago. But what you have to be even more careful about today is what CT scanners you use, because there's a lot of inaccuracy in the images, and it's very hard to really get consistency for measurement. So here we see that scans taken within 2 seconds of each other had a 44% change in volume, and that meant it was a malignant nodule, but it's not. It's just a phantom sphere that you have. So early on, in I think around 1992, I called up Rome Laboratories. Rome Air Force Base is where the U-2 spy planes took off. Most of them took off. And I said, well, now that the Cold War is over, I said, I'm sure you develop techniques for automatically detecting what goes around the world. And they say, yes, we did, but we still use people. We rely on people more. But I worked with that group, and we said we could use that same approach, which was AI at that time, neural networks they were called, and said, how can we use it for detection of nodule and growth and assessment of the risk? And that led to several abstracts, and the article in Business Week on those abstracts were searching for lung cancers instead of tanks. It took us at that time a long time to publish that paper, but we eventually got it published. And then really it took the development of computers and the statistical techniques to drive it to where it is today. We now developed an open source software. We're developing it in order to integrate and to do the assessment of the CT scan. So for a national lung screening program, you want to identify the screening technique, the acquisition technique, the workup, and where you can do the treatments. You want to develop a recruiting strategy for participants. That's really key. You want to develop quality assurance, and I can't stress that enough. At each step of the way, you have to have quality assurance. You need to have a management system that communicates with your radiologic system and the hospital management system. And you need to continually update your protocol. And you need to connect it with long-term follow-up with the National Death Index or registries in the country that you're working on. So the current options are really to have annual screening or biennial screening every 2 years. And we really should consider CT screening, chest X-ray screening as well. And we'll hear more about that. So in the US, after the NLST publication, In 2016, the Centers for Medicare and Medicaid Services provided reimbursement, and the institutions really had to meet that provided the screening had to meet the ACR standards, which was for radiology training and data entry. The enrollment criteria were first based on the NLST, and with the publication of the Nelson, they updated, and hopefully they'll update further. The other one that I'm familiar with, it used a very different model. The Croatian National Screening Program started in 2020, and they had had a decade more of experience with population-based screenings in breast, colorectal, and cervical cancers. And lung cancer is the leading cause of death and they have a very low rate of stage 1 lung cancers. So they did it differently. They centered their screening practice at their general practice clinics throughout the country. And they had a well-developed communication system among all the clinics, and it's linked to the National Registry. They reviewed the published protocols and decided at that time to use a modified I-ELCAP protocol. And they started enrolling people 50 to 75 years, 30-pack years of screening, current smokers or quit within the last 15 years. And despite COVID in between, they've now screened over 30,000 high-risk participants in a well-integrated national program, the first in Europe. With Bristol Myers Squibb Foundation has been very active in Africa, in multiple countries, really developing a lung cancer control programs. And they decided that they would help fund the Ethiopian early lung cancer detection. So they first developed a Ethiopian Respiratory Society that came up with a very comprehensive manual on diagnosis and treatment of lung cancer. They developed a comprehensive risk assessment for qualification of the screening. It's supported by their Ethiopian Ministry of Health and by the Bristol Myers Foundation. We've identified 2 hospitals in Addis Ababa to start screening. We've developed an annual screening protocol, received IRB approval, and we installed the Screening Plus management system with AI, and we started training, and we're just starting this week, and we're integrating a incidental nodule detection in the TB clinics and so on. So the AI, as I said, has been added to the Screening Plus management system. And in the future, we hope to integrate AI for coronary artery calcification, other cardiovascular disease indicators, emphysema, and other such applications. And the Ethiopian government is very much interested in those developments. Thank you very much. I hope I speeded it up. Matthias?
Yep. Yeah, we tried from a different angle to have a look at the global developments over the last 5 years and address then the key issues from what everyone is studying and publishing. So if this is from, everyone knows this global policy network on lung cancer, and here you can appreciate that there are studies that are active. So those are studies that should be active, is self-reported. And then there are 90 in the US, the same number in Europe, 26 in the region of China, in Kazakhstan, 5, then in Australia, New Zealand also 5, and then also some registered in Brazil. Now, if we look to the, so you can just search on CT in lung cancer screening, and over the last 5 years, you'll find 2,515 publications. And you can see here also the distribution. So that's primarily, it's very interesting, the US and China. But as you know, Europe, I made a little extra count for Europe as a whole. Then those are the 3 major regions, continents that are doing the contributions in those publications on CT lung cancer screening. And if you look to the funding, then you can see that the Ministry of Health, the National Institute, the NIH of the US put the most money in this, But then you see many from China. So China is also really funding a lot. And then you see Europe again, we are always down with the funding. So we are not spending that much money. Then if you look to the risk assessment and in lung cancer screening, then the US is publishing far out the most, then China. And then the other countries are far lower. If we have a look at, and that is a major trend that we are not addressing in this meeting, and probably we should also address this, that is the epidermal growth factor receptor in lung cancer screening. It has 1,244 publications over the last 5 years, and it's especially of high interest in China, but also in the US and almost not in Europe. So that's also quite interesting information, I think. Then we go to AI in lung cancer screening. And what is interesting, 5 years ago, there were almost no publications on AI in lung cancer screening, and it really boomed more than any other subject in lung cancer screening. And you can see here that also the United States and China are in the top. But if you look to the affiliations, then you can see you have Harvard Medical School, but 2 times Groningen. So I'm very proud on this, on that output, you understand. But if you look to the funding sponsors, you can see here that, again, the US, but also China, has far out the most sponsoring in AI in lung cancer screening. And there are 632 publications. Then we look to the risk modeling, which is, of course, also a very important subject in lung cancer screening, that you have 616 documents from the last 5 years, from the US the most, and then China, and then all the other countries are a lot less compared to those 2. Then followed by surgery in lung cancer screening. So I tested that for segmentectomy and VATS, video-assisted thoracic surgery. And there you see that it all comes, China has the most studies on this, then the US, and also the UK, and the European countries stay behind here. But if you all count them up, they are also quite substantial. Then stereotactic radiotherapy in lung cancer screening, and that is dominated by the US. So that's also important to know. Then China, and the other countries, if you here count up the European contributions, then it's also substantial. And last but not least, the combination of EGFR in CT lung cancer screening and CT. And then you see that it's of high interest in China. So they try to analyze with AI the CT images to predict if those by all kind of analysis, the EGFR positive cases. And also in the US and Japan, this is interesting, but not in the other countries. Now, altogether, you see here in a row the key global research developments in lung cancer screening over the 5 years in terms of publications. So CT and lung cancer screening as a whole has this 2,515. Then you have the risk assessment, then the EGFR measurement in lung cancer screening, then AI as from out of the blue, already at the 4th place, and I expect the coming years it will be the first one. Then the risk modeling, which is still very important. Then the surgery in lung cancer screening, and then the radiotherapy in lung cancer screening, and then the EGFR prediction in lung cancer screening, CT lung cancer screening. So those are the big trends that should also be, I think, of interest for this meeting. Then March 31, so 2 days ago, the recommendations of the Dutch Health Council. So we have as only country in the whole world, we have a separate legislation on screening. So population screening can only be done with a special approval of the Ministry of Health. And the Dutch Health Council is instrumental with their advice for this implementation. So for us in the Netherlands, that's important. And they came out with 3 recommendations. So they say, okay, in the foreseeable future, we can implement the screening program, but The target group, the optimal screening interval, and the number of screening rounds has to be determined before we implement. Then we need more information on referral rates, false positive results and numbers, and the nature and consequences of incidental findings. I think all relevant also for what we are doing here. And they want to know more on selection of the target groups and the care capacity. So that is, yeah, more or less different for any country and any situation. So also for us in the Netherlands, we have there, I think, a national tailored approach. Also very important is to realize that there are new AI regulations and recommendations that will come in place this year and later on. And this is the EU AI Act timeline, and that is starting more or less now. So in February 2025, AI systems classes will be classified as unacceptable and banned in the EU. And here you see then the risk descriptions in that act. So there is an unacceptable risk for all AI systems that are considered a clear threat to the safety, livelihoods, and rights of people. So I don't know how they will look to this in medical devices, but I think without validation, it will be an unacceptable risk. Then you have high risk, limited risk, and minimal risk. And that is how they want to classify more or less AI applications in Europe. So altogether, there are new AI regulations and recommendations coming on. I think this will be very important also for what we are doing if we implement AI. And so the key issues for AI for the integrating of B3 early detection is how do we apply AI in population risk stratification? Do we want to do this? And how do we do it? And how do we validate it? The same goes for the fully automated participation invitations. It goes for the CT planning and protocols. It goes for the clinical decision making. And here we will address in this meeting also for the radiological read analysis, and then also for automated radiological report generation. So all those things should be addressed. If we don't do it, it will be asked from us that we will answer those questions. So the key issue will be no AI implementation without validation. Thank you for your attention.